So, urothelial cancer, I have a slide and it says bladder cancer, but I'm talking about upper tract here. So I think most of us are labouring under the belief or are under belief that perhaps all urothelial cancers are the same. Regardless of one thing or another, it's a big black box, there's molecular biology in there, and one tumour is the same as the next. So I guess our null hypothesis is that the bladder TCC, UCC is the same as a ureteric one, is the same as a renal pelvic one, and that's not unreasonable because we treat them often in the same manner. But if we look outside of urology, that's not the case. So breast cancer is probably the best example. We've known for a long time that there's familial breast cancer, and this has enabled us to shave off pieces of the breast cancer puzzle. So you've got those with BRCA2 mutant families, those with BRCA1 mutant families. Then you find that a proportion of sporadic tumours also have these mutations. And suddenly the disease can be sort of salami sliced, and we can understand it a bit better. If you're a molecular biologist, this is fascinating, but if you're a clinician, you wonder, is this relevant or not? And that's all until we then work out a bit more about the disease. So a few years ago, we worked out that BRCA2 was to do with DNA repair, and when you have a double-strand DNA break in a cell, the cell goes into crisis. It's got to repair that or else it dies. And BRCA2 is vital for that cell, and it's the mutation in BRCA2 that enables deficient ones to keep surviving. Then another group of experimenters worked out that this pathway had some duplicity, and there's an enzyme called PARP, which was the salvage mechanism by which the cell survived. Lo and behold, PARP inhibitors have been discovered, and suddenly we find we've got a very specific treatment that inhibits and kills all cells that are deficient in BRCA2. And so suddenly we have a new treatment that will target only BRCA2 mutant cells, and this has been a big breakthrough in breast cancer. So I'm here to present and suggest that upper tract TCC may be a mechanism that enables us to do the same in urology. I'm going to talk a bit about the demographics, as you can see here, pathology and etiology, etc. So most of us know a fair amount about upper tract TCC. We see it in our practice fairly frequently. Accounts for between 5 and 6% of tumours, about 10% of renal tumours. We know there's a predominance of renal pelvic tumours compared to the ureter, and apart from some various geographic variations, it generally pitches on about the same instance as bladder cancer, as you can see here. There's been an increasing frequency for reasons we don't understand, and one of our problems in the disease is that it's recorded differently by different tumour registries. If we look at age demographics, and this is some from Sheffield here, it pretty much overlaps with bladder cancer, as you can see here. The main difference is there's a higher female preponderance, and that probably reflects some of the etiology we'll talk about. If we look at the pathology, we're all aware that upper tract TCCs as a whole are worse than bladder cancers. So as you can see here, we've got bladder at the bottom. We know most of our tumours are PTA. A predominant number of them are low grade, but in the upper tract that's not true. Up to 50% of tumours are invasive when we find them. A much higher proportion of them are high grade. And it's unclear if that really reflects a different disease or perhaps they just present later. Perhaps they're harder to find. We know that often people can have a number of rounds of investigation before they're picked up for their upper tract TCC. And perhaps the low indolent ones disappear on the way through and the patients don't present any further. But there are differences in etiology. So if we look at nephropathies to start with, and this is where my interest came in, there are various nephropathies that give upper tract cancer rather than bladder cancer. Perhaps the best known is Chinese herb nephropathy, and this is to do with aristolic acid, which is a contaminant of a Chinese herb, the mufangji pill, as you can see there. And patients who have exposure to this have a much higher preponderance of upper tract disease. In fact, 90% of tumours are in the upper tract, and that's obviously dramatically different to sporadic cancer. Then there's the geographical variation. So in the Balkans endemic nephropathies, there are high prevalence of upper tract TCCs in clustering of geographic locations around different parts of the Balkans region. And the likely culprit here, once again, is aristolic acid. It turns out this is a contaminant of some of the yeast that's used in the bread in those regions, and after a long circular epidemiological investigation, we now think it's probably the same disease as aristolic acid nephropathy. But once again, you have much higher risk of upper tract TCC when compared to bladder cancer in these patients. And then in the other one is paracetamol or its derivatives Phenacetin, and this may be one of the causes for why I have a female preponderance of the disease. I believe when I was in Australia I heard a campaign that in the 60s and 70s there was have a cup of tea, a Beck's and a good lie down for women. I think it's probably a bottle of wine nowadays, isn't it? But it was routine to take Phenacetin, aspirin and caffeine, and it was seen that that was a good thing. We now know this can cause some papillary necrosis, this causes local damage to the kidney, but more importantly causes upper tract TCC. You have a 5 to 12-fold increased risk, and between 11 and 22% of upper tract tumour patients have a history of what we'd call abuse, but at the time was just regular taking. There is some anxiety. Phenacetin is a derivative of paracetamol. They're related in familial structure. But we think nowadays, and from rat models, and the relative risk in people who take a lot of paracetamol don't suggest that this structure, this drug gives you the increased risk. But there's certainly some proximity chemically. If we look at occupation, a lot of the occupational risks also overlap with bladder cancer. The best evidence comes from the Swedes, as for many of these regions. And I was thinking today about the BAUS registry and various reasons why the Swedish registries are so good. And I did a search a while ago, and I found out that in Scandinavia, and in Sweden in particular, it is illegal to not fulfill a medical record. So if you're a doctor treating a patient, you can end up with a fine or in prison if you don't fill out registry data on patients. And perhaps that's why they have such a high thing. So Tim, got it from me first, eh? Use that for BAUS. So they have 4.4 million people's follow-up for 16 years, as you can see here. And they looked at a variety of urothelial carcinogens and various occupations. 20% of their cohort had changed occupational group over the time. But what we saw is that a predominant number of them had metal working exposure. 14% of them had got renal tumours, renal pelvic tumours, had got heavy metal exposure in the past. And we know there are various carcinogens, such as heavy metals or some of the azo products that are used to clean metal, or the mineral oils that people get contaminated with. For women, there was an increased risk in pharmacists, journalists, business executives, and a lot of white-collar workers. And again, the theory there is that they probably end up in the generation that the risks were occurring, there was a lot of typing, and a lot of secretarial staff had heavy contamination of typing on their hands, and at the end of the day, they'd have black hands from the print. Likewise, some of the sort of white-collar workers in the men were also involved, men were involved as well, but again, it was mostly heavy manual work and metal work. In Australia, dry cleaning was linked, a relative risk of 5-fold for patients with exposure to dry cleaning agents, and the key carcinogen likely there is tetrachloroethylene, which is a IARC2A carcinogen, which means it's a probable carcinogen, but they're lacking the final proof. And we know that can cause bladder cancer. Once again, iron and steel were implicated. And this is a salient point, and I think this is true for bladder cancer as much as upper tract, is that we're likely to see a change in the disease over the next few years. This is the 2007 urothelial cancer incidences around the world, according to the Globocan, which is one of the IARC agencies. If you overlay that with the gross domestic product, so as a surrogate for the occupational exposure and industry in a country, you see they often lie pretty closely together. But if you look at that going forward, if you look at the growth rate in a country compared to its current GDP, we know there's going to be a big skew of this disease towards Southeast Asia, India and China. And indeed, a lot of the epidemiology journals are now full of reports of exposure in Chinese workers to practices that have been outlawed here for the last 30 years. And so it's likely that there's going to be a big shift towards bladder cancer developments and expertise into the Far East. There's also some contamination issues. So I believe in about 30 years ago in Bangladesh, there was a series of droughts, and the World Health Organization went in and drilled wells with all the best will in the world to maintain the water supply in these regions. What they didn't know is that these wells were going down into contaminated water, and so they were actually producing for the local people very high levels of arsenic and cadmium in their water supply. And this is leading to a massive outbreak in bladder and lung cancer and upper tract cancers in this region. And the most recent report now suggests 5 to 10% of cancer deaths in Bangladesh are due to this contamination, and it's only on the upslope. We're going to see even more of it over the next few years. If we look at other etiological factors, tobacco smoking is one of the key ones, and again, that's no surprise. Those of us who work with bladder cancer know they go hand in hand. About 50% of tumours are thought to be due to tobacco smoking, and the data in upper tract shows no difference to bladder cancer as a whole. And then the area that was most interesting to me is in the hereditary syndromes. As you saw at the beginning, when we look at breast cancer or colon cancer, it's the hereditary syndromes that have enabled us to unlock the disease to try and work out the biology of what happens in a minority, but actually is probably one of the main pathways in the majority. And in Lynch syndrome, we have a tumour spectrum whereby upper tract tumours can occur. This is the commonest familial syndrome, and it was first described in the 1890s by Aldred Wharton. It accounts for about 5% of colorectal cancers, but up to a third of tumours are not colorectal in their site, and in fact 13% of all of them are in the ureter or the renal pelvis. You have between an 8 and 16-fold increased risk for upper tract TCC, and overall we think you get a 1-fold, i.e. no increased risk of bladder cancer, although there's some debate about that. But importantly, the patients have about a 4% lifetime risk of upper tract TCC. This is the typical case, or the familial pedigree. This is a case we found in Sheffield, where the index case is arrowed. We had a female who at 45 had an endometrial carcinoma, which she'd had excised by the gynecologist. A year later, she'd had a cecal tumour excised by the colorectal surgeons. And then 3 years later, she presented with a distal ureteric TCC. And it's only about then that people are starting to sort of get the picture and the penny drops. When you take a history from her, she's got a fairly strong history of cancer, all generations affected, but as often the case, she can't remember more back than her grandparents, so it's very incomplete. When you look at the DNA in these people, we know the genetic cause for this syndrome, and they have a defect in their DNA repair. This means that they develop tumours across the board, and you can detect this DNA change to enable you to understand why and to confirm the case. It also helps us understand about multifocal disease. So the other great risk factor for upper tract cancers is a previous bladder cancer. We know that if you've had an upper tract tumour, then you've got about a 50% chance of having a bladder cancer. That's been shown in a variety of studies, including the ODMIT study, where you had a 27% chance from Bausch Oncology. You have about a 1 to 5% chance of it going to the other side of the upper urinary tract. And then likewise, if you've had a bladder tumour, you've got about a 1 to 6% chance of having an upper tract TCC years down the line. These factors are predictive, as you can imagine, of multifocal disease. So if you've got multiple tumours, if you've got carcinoma in situ, or if the disease is more aggressive, high risk, high grade, then you're more likely to get tumour. Likewise, if you have urethral involvement as an indicator of multifocal UCC, then you're more likely to get upper tract tumours. But you can use the knowledge from hereditary non-polyposis colon cancer to map these tumours out. So we took a patient, and this is the case that you saw the family tree of earlier. There we've got various microsatellite changes across her DNA. L is the leukocytes, the normal picture. C is her colonic tumour, which is mutated. UR is her ureteric, and then a subsequent bladder tumour, and then E is her endometrial cancer. And you can see that each signature is completely unique, apart from the 2 urinary tumours, which are identical. That's the same for 1, 5, or in fact we worked at about 30 different loci. And you can generate tumour trees. So this particular lady had a very interesting picture in that she'd had a cystoscopy that was normal, she'd had a nephrouterectomy, she'd had 2 cystoscopies down the line before she developed a bladder tumour 12 months later. But genetically, the bladder tumour came off further upstream, it was less unstable, it had less mutations, so it had probably been there all along, but it had just been growing slower and slower. You can pick up these in a variety of patients, so we've done about 10 patients now, and you can get from fairly simple to fairly complex molecular trees. It's underlying the fact that this disease is panurothelial, and even though you think you've cleared it, even though your margins are negative, you have genetically identical mutated tumour cells elsewhere in the urinary tract. So they must be spreading along or shedding down, or perhaps the disease is spreading along in such a way that the histopathologist can't identify it. When we looked at our overall population, we saw 77% of them were genetically identical. There was one that was probably related and a couple that were completely different. So that gave us a quota of about 80% of the tumours that were genetically strongly related. Can we use this information? Well, if we looked at this phenotype, these microsatellite unstable tumours, they account for about 15% of upper tract tumours, but only 1% of bladder cancers. That's very similar to the colon. In the colon, 15% of cecal tumours, these are sporadic, not hereditary tumours, have this phenotype, and 1% of rectal tumours have the phenotype. Colonic pathologists know that if you've got a young patient with a right-sided tumour, they automatically screen for the presence of this disease. In our disease, I've found a number of these families and a number of sporadic tumours, and the predominance is for a distal ureteric tumour. They're mostly in women, and they have a classical pathological inverted growth pattern. If you ask your pathologist, they can often spot them for you. And the same is true in colorectal cancer. They tend to be cecal, they have a mucinous histology that's characteristic, and they tend to be more common in females and younger patients. This is important. Firstly, these tumours do better than you think, because they have so many genetic abnormalities, these cells find it hard to progress forward and form metastases. And in fact, they're far more indolent than they would appear histologically. So it's nice to have a prognostic view. But they also affect their response to treatment. So the DNA repair enzymes that repair these mutations are also the DNA repair enzymes that kill a cell when it has cisplatin-induced damage. So if you take a tumour and if you give a patient cisplatin, these cells are inherently resistant to cisplatin. And we know that from colorectal work. So here's an adjuvant study of colorectal chemotherapy that was based around 5-FU with some cisplatin use. And we saw that people who'd been given adjuvant chemotherapy did better overall if you took all tumours, but if you stratified them according to their DNA repair architecture, they actually did worse. They had a higher mortality, far more complications, and far less response to the treatment. So in colorectal cancer, there's now advocates that suggest you should screen and treat people accordingly to their genetic phenotype. You can identify this in the clinic either using a variety of criteria. If you have colorectal cancer, you can look for 1 or 2 first-degree relatives who are young, 2 or 3 successive generations, and looking for 1 other syndrome-associated cancer whilst they're at a young age. And in colorectal cancer, you need to exclude familial adenomatous polyposis. This is a second criteria, effectively looking at the same thing in a different way. What's important is that your pathologist can give you a good idea as to whether they're going to have this mutant phenotype from their inverted growth, distal ureteric nature, and the femoral preponderance. So, from taking our only familial syndrome that we can use, we've found over the years that 15% of upper tract tumours have this DNA repair defect. It's more common in the ureter than the bladder, but only about 1% of bladder cancers have it as a whole. We don't have another familial syndrome to help us with, so we're going to have to extrapolate from other solid cancers to try and unlock the rest of it, but it's likely that we'll be having shared common pathways. I was asked to talk a bit about the forgotten tumour, and I think the only thing I can add to the molecular biology is where can we go with clinical studies at the moment. I'm about to hand over to Alison to talk about the POUT study, which is very important, but I think there are other issues that as urologists we could perhaps address. I think there's a third of these tumours are low grade. I suspect most of us are still using nephrouterectomy for distal ureteric low-grade tumours, and perhaps we need to get together and organise a trial to look at regional resection. I certainly know of good evidence to suggest in low-grade disease we should be thinking of segmental ureterectomy, and maybe we should work along that field. I think high-grade disease and lymphadenectomy is another surgical area that we can try and address. We can try and put a robust study together, and I won't steal too much of Alison's thunder regarding adjuvant chemotherapy. But I think, you should congratulate yourselves. As Tim has shown, you can do studies such as the ODMIT-C study, and I think we should try and move forward because it's such a low-risk tumour. We're not going to do that on our own. So in conclusion, there are differences in the etiology that suggest there is an acquired element, there's a congenital element for a proportion, but the vast majority come through differential risk factors than for bladder cancer. And I'd like to thank my funding. Thank you very much.